Hey y'all, so the cancer site that we decided to look at today is known as non-small cell lung cancer, aka NSCLC. So just a quick little breakdown of how the presentation is going to go. Part one really talks about the molecular biology of this cancer and really just looks at the development of NSCLC on a molecular level. Part two is going to be the epidemiology portion. And then lastly, part three is going to talk about our target intervention. So starting off with part one, what is NSCLC? So as mentioned earlier, it is non-small cell lung cancer. This particular cancer makes up 85% of lung cancers, which is a pretty big percentage. And they mainly originate at the epithelial cells that are lining the bronchi and the alveoli. Those who have taken anatomy and physiology know that these are two very crucial portions in just simple breathing. So when you have obstructions or difficulties with the bronchi or alveoli, you have shortness of breath, difficulty retaining oxygen, which can also lead to different imbalances within other body systems. There are three main subtypes of NSCLC. The first one would be adenocarcinoma, which is usually the most common, and that takes place within the peripheral lung. And then you have squamous cell carcinoma, which happens in the central lung. And then you have large cell carcinoma, which is the least common, but it is also the most undifferentiated. Going back to the squamous cell carcinoma. Squamous cells are basically flat cells that are on the surface of the epidermis, as well as within body cavities. So this type of lung cancer specifically affects the cells that are within the body cavities, which in this case would be the lungs. So getting into the different subtypes and the mutations, each of these subtype is product of a different mutation within a cell. So here are just a few examples. Adenocarcinoma is affected by the EGFR, ALK, and the KRAS mutations. The squamous cell carcinoma is byproduct of the TP53 or the CDKN2A mutation. So within different mutations, you have different biological effects that occur within these different subtypes. So you see that the different subtypes each have different mutations, which therefore lead to different outcomes. And in this case, it is the location of where the cancer or the tumor originates. And NSCLC also is one of these cancers that kind of bypass early detection because of how slow it is to progress. So with other cancers, it's a lot more easier to detect because there's screening programs and things of that nature. But because it is such a slow developing cancer, it really does take a bit to be able to recognize. And most of the time, it's not recognized until symptoms present themselves. And then just highlighting the most frequently mutated, which would be the TSG-TP53 mutation. So within non-small cell lung cancer, the TP53 mutation occurs within 50% of cases. So half of NSCLC cases are due to the TP53 mutation. So just a little information about TP53. The normal function of the TP53 gene is to activate cell repair. It also can arrest or stop the cell cycle. And then it can also initiate apoptosis, which can get rid of damaged cells. The TSG TP53 mutation is a quality control protein. So its main job is to detect DNA damage and to ensure the quality of a specific protein. But when you have a mutation within the TSG TP53 gene, you initially experience a loss of function, which results in cells being able to mitigate apoptosis and continue to accumulate mutations. This will just ultimately make it even more difficult to treat because there's so many mutations that are having to be targeted within a cell. And then just highlighting on the hallmark of cancer, this hallmark would be considered evading cell death and genome instability, which also makes it gives it one of the quotas of a cancer cell. And then for this little last section of part one, we have immune evasion in nivolumab. So within this, as I mentioned before, the hallmark that this takes on is evading cell death. And this does this mainly by destroying T cells. T cells within the body are used to basically fight off any foreign bodies, any disease, any bacteria within the body. And they really work by recognizing things that aren't supposed to be there and they fight against them. So by having this invasion of the immune system, you see that the T cells are destroyed, which therefore lessens the body's ability or the immune system's ability to fight off things such as cancer. This takes place via the PD-L1, or also known as the programmed death ligand 1, which is overexpressed in tumor cells. And then hitting on the immune checkpoint pathway, the PD-1, which is an inhibitory receptor, is activated, which therefore leads to preventing the immune system from being able to attack the tumor. Looking at this image here, if you can see, the tumor cell that has binded to the PD-L1, and then the PD-L1 that is also binded to the PD-1 has turned off the T cell, therefore limiting the body's effectiveness in fighting against different things. But just briefly touching on intervention, the Opdivo treatment plan works to restore these T cells. So it basically reactivates the T cells, turns it back on, and essentially allows the body to be able to continue to fight off things such as cancer.
Now, going into the epidemiology of non-small cell lung cancer, why is NSCLC a public health problem? Well, due to its high incidence and mortality rates or death rates, as well as the strong association with preventable exposures such as tobacco use and radon exposure, which we'll go over in a bit, and there's also many disparities in diagnosis and outcomes. Despite being largely preventable, underscreening and continued exposure to risk factors make it one of the most lethal cancers worldwide. So, non-small cell lung cancer, as we said earlier, constitutes approximately 85% of all lung cancer cases. And according to SEER and the American Cancer Society, the incidence of NSCLC is 47.8 cases per 100,000 per year, and the mortality rate is 31.5 per 100,000 per year. Most patients are diagnosed with advanced disease, as Morgan said earlier. It's harder to find because it progresses so slowly. So that can contribute to the high mortality rate since they're diagnosed at a later stage. But the relative 5-year survival rate is about 65% when in early stage NSCLC, but varies dependent on the stage, with regional spread at about 37% and distant metastasis at 9%. Now, how this varies from person, place, and time. Men historically have had higher incidence and mortality, but rates among women have been increasing, reflecting changing smoking patterns, which is a big risk factor. Most cases are diagnosed in individuals over the age of 65, with the median age of diagnosis being around 71 years old. African American men have had higher incidence and mortality rate than men, but it's important to note that this finding can be due to socioeconomic status and access to healthcare between different people. And then geographical variation is evident due to differences in smoking prevalence, occupational exposure, and environmental pollution, such as radon exposure. For example, regions with higher radon exposure or coal mining activity tend to have elevated lung cancer rates. Lung cancer rates have been declining among men due to decreases in smoking, awareness of the risk factor. And the adenocarcinoma, as Morgan talked about earlier, one of the subtypes of the NSCLC, has become the most common histological subtype, overtaking squamous cell carcinoma, and this is likely due to changes in cigarette design and inhalation behavior. So I chose a observational study from PubMed, which is actually a narrative review drawing from different cohort and case control studies, some from the American Cancer Society and some from EPIC, the European Prospective Investigation into Cancer. So as we know, narrative review studies do take the most high quality studies that have the most statistically significant findings. So that can be a reason for why this is quality. What I've gotten from the study is quality findings. So what they found was approximately 85 to 90% of lung cancer deaths are caused by cigarette smoking, or they had an association with cigarette smoking and getting lung cancer. Heavy smokers have a lung cancer risk 20 to 30 times higher than never smokers. And they categorize heavy smokers and light smokers based on pack years. So they found that the risk is dose dependent and increases with pack years, and they found quitting lowered risk over time. So they did find a dose response association with this. So saying cause is not really accurate, but from all of their findings, it gives pretty good evidence to it being a pretty big risk factor in causing it. The latency period, they found lung cancer often develops 20 plus years after exposure begins, which can explain why the median age of diagnosis is around 71. The risk is highest in current smokers, reduced in former smokers, and lowest, obviously, in never smokers that they found. And the study also did look at many different risk factors and saw that smoking had the greatest association. And this evidence is highly useful for shaping individual and population level interventions to prevent NSCLC. Mostly just awareness of this risk factor can help a lot of people. So the intervention study that I found, I actually chose 2 randomized control trials. One that was looking into squamous non-small cell lung cancer and non-squamous non-small cell lung cancer. I chose to do both just so we could get all different subtypes of this disease. And they were comparing nivolumab or Opdivo versus docetaxel. And the risk versus benefit analysis, they found a longer overall survival and better responses in some patients, fewer high grade, which are grade 3 to 4 adverse events than in docetaxel, and better quality of life, less fatigue, nausea, neutropenia. The risk did include immune-related adverse effects such as colitis and hepatitis, and it did require monitoring and management of autoimmune toxicity. And they found it to be not effective in all patients, especially those with very low PD-L1 expression. The cost versus benefit analysis, nivolumab or Opdivo costs approximately $14,000 to $15,000 per month, so that is a pretty big chunk. But we economically justified it by it actually found to be a cost-effective option in patients with PDL levels greater or equal to 1% and higher when long-term survival benefit is realized. So with the benefits being like feeling better, it may be a little bit more expensive, but they found better outcomes in certain patients based on the PDL1 levels. They did find overall nivolumab to be the better option. And then if you look at this little chart I made from their comparisons with nivolumab and docetaxel and their hazard ratios, as you can see, the p-value is well under 0.05. So they did find these to be statistically significant. And for a little interpretation of those numbers, they found a 27 to 41% reduction in risk of death versus chemotherapy. And the survival benefit was observed regardless of PD-L1 expression in squamous non-small cell lung cancer.
All right, so wrapping up, we're just going to talk about the target intervention of NSCLC. So as we touched on earlier, the Opdivo treatment targets specifically the PD-1 within NSCLC. Like I stated, is also known as programmed death 1. So this is a immune checkpoint receptor that is on T cells. And so what happens within the treatment of Opdivo, the PD-1 binds to PD-L1 or PD-L2, depending on the case, and then it inhibits T cells to be reactivated, or it inhibits T cells being activated. So it allows tumors to be able to mitigate the immune system. And so with nivolumab, this antibody binds with the PD-1, which blocks it from interacting with PD-L1 or PD-L2. And essentially, it allows the T cells to remain activated and therefore can continue to fight off the cancer. And unlike chemotherapy, this treatment does not target the destruction of cancer cells. If anything, it just inhibits the T cells so they can work on fighting against the cancer cells. So essentially, Opdivo just aids the immune system, and that way the immune system is able to fight off the cancer or fight against the cancer. And then talking a little bit about specificity, flashback to Bio 101 or 201, where we talked about substrates and enzymes having high affinity for each other, and basically where certain enzymes can only bind with certain substrates and vice versa. So this is similar. So PD-1 does not bind to CTLA4 or any other immune checkpoints. So with the Opdivo treatment, this is really good because it can target specifically PD-1. And it is designed to minimize the FC-mediated effector functions, which also aids in reducing the immune system's ability to fighting off cancers. And then lastly, it just talks about a little bit of the more realistic approaches to Opdivo. So since NSCLC makes up 85% of lung cancers, that means that a lot of the lung cancers that people have are most likely non-small cell lung cancers, and falling into any of the subtypes. So as we mentioned before, because it is such a slowly progressing disease, it is often diagnosed later down the line. And 9 times out of 10, patients do not recognize it or it's not diagnosed until symptoms have presented themselves, such as cough, chest pain, weight loss, etc. Nivolumab is usually used within higher risk cases of NSCLC, typically after chemo has been failed. So it's usually like a backup to chemotherapy. Despite the fact it does improve survival and it also offers durability in patient response to the treatment, therefore improving patient quality of life. A few of the side effects do include mild fatigue, sometimes rash, and other immune-related issues. So because Opdivo does target the immune system, although it may be aiding the T cells within the immune system to fight off things such as cancer, it can also cause other immune system related diseases, like inflammation within the lungs, colitis, etc. And just like pretty much all cancer treatments that are out there, resistance can occur as to why Opdivo is mainly used within combination therapies in correlation with other drugs, therefore maximizing the best quality of life for a patient. It is warranted that because resistance can occur within this disease, that patients and providers are really making sure that treatment is being applied effectively and is also being applied effectively with other therapies.
And we have our sources listed here. I do want to note the studies for the observational intervention studies. I linked directly on those pages. but these are all our other sources that we use. Yeah, I think that's all we have for you guys.
Thank you.
Thank you.